Great. Welcome back to the House Healthcare Committee. It is Friday, January 19th. We're in home stretch for the week, and we have the pleasure of having Sandy Hoffman from DVHA back with us. We had a little technical voice issue yesterday, so thank you for coming back this morning. And this is in regards to 766, the prior authorization sections that we've been talking about. And the bill itself is for commercial insurance, but we feel it's really important to understand what DVHA does in regards to prior authorizations for our Medicaid insurance program. So Sandy, I'm going to turn it over to you.
Great. Hi, thanks for having me. For the record, I'm Sandy Hoffman, the Deputy Commissioner at the Department of Vermont Health Access. I appreciate the opportunity to talk with you about the DVHA practice, and I also think the delay is great because the CMS interoperability and prior authorization final rule came out yesterday. So I can give some high points of that. Yeah, right after this ended, it came out. So
Great.
I asked the policy team to weigh in and give us an overview.
Okay, so maybe we can just start with when you say they commit, like what is it? Who is it? What do they do? And then we can go into how it affects us.
Sure. There are two main parts of the rule. It affects Medicaid programs, and it requires Medicaid agencies to implement and maintain application programming interfaces, APIs, and this is kind of the technical stuff is out of my realm, but what I can say is it makes it so that insurers can access clinical records, thus negating the need for the providers to submit additional documentation to support prior authorization requests. That it would allow us to look at what the request is in the medical record, as I understand it. And that requirement is for implementation by 1/1/27. And it also requires the an electronic prior authorization process for medical services by that same date. That doesn't apply to drugs. And this would increase information sharing, reducing additional administrative burden for the providers pertaining to prior authorization. Okay, that's kind of over.
That's great. So I just want, so new rule allows DVHA to look in the electronic health record rather than asking providers to submit information, and it's going to require an automated process for medical prior authorizations. Okay,
right,
great.
which we've been and we've been exploring that anyway through our provider management module, an opportunity for providers to use that system to submit prior authorization requests. So we're on it. I guess that's what I will say. So there's been a cultural shift at DVHA regarding prior authorization. In January of 21, in response to legislation, a multi-unit work group was established to assess the prior authorization requirements, and the group was asked to focus on opportunities to remove prior authorization and that administrative burden, align requirements for ACO and non-ACO attributed members, and align with other insurers whenever possible. The public health emergency and the DVHA response to it also provided us with data to consider when evaluating the need for prior authorization. For example, we removed the PA requirement for imaging, dental, and DME, durable medical equipment, in response to the health emergency. We tracked the utilization patterns absent the PA requirement and saw there was little shift in utilization. And then we continued to monitor the utilization trend. That data informed our decision to make permanent the suspension of PA for DME, most dental services, and imaging. And the PA work group meets every other week. The first 9 months focused on the review of many different disciplines. They included some of the disciplines we reviewed include occupational therapy, physical therapy, speech therapy, chiropractic care, hysterectomies. And the initial review and determinations were included in the report that Sebastian referenced yesterday. And I'll say that we did align ACO and non-ACO attributed members and aligned with other payers when possible. The team identified opportunities for monitoring to ensure that there were no sudden inexplicable upticks. And part of this strategy was to address the concerns that were identified by our Special Investigations Unit and the Clinical Utilization Review Board. And both of those were consulted during the process. We continue to monitor those reports and the findings, and we report out to the CURB and the Special Investigations Unit. The team also reviews services regularly determined to determine the need for continued PA. We do have an imminent harm code list, and that list is reviewed annually. That means that the member might be at risk should those services be implemented without additional clinical review. We also look at the limits to services. For example, this year we increased the 25 per year outpatient mental health visit limit to 260. We haven't seen the use at that level, but recognize it might be needed, and we want to allow it when it's clinically appropriate. We also work with our partners to identify opportunities to remove PA based on specialty access issues and high approval rating. Another practice that DVHA has employed is reviewing the exception and appeals data to ascertain whether additional services should be covered with or without authorization. When we see patterns, we do a clinical review and present the findings to a multidisciplinary team that meets biweekly. That team considers the federal requirements, system challenges, integrity risks, coding challenges, and then makes recommendations to the DVHA leadership and the Clinical Utilization Review Board when appropriate. All of this is just to show that we're committed to reducing provider burden. We get it. Again, the cultural shift has our team trusting the provider knows what is best for the member. We want to support that relationship, and we have federal requirements that we must adhere to. As far as the PA turnaround time, we adhere to the federal requirements always, but we have internal goals and we have scorecards that show that the time is dropped significantly. In prior years, there was a delay in our turnaround time because we were always looking to get to a yes decision. And we used an informational status that would indicate there was a longer turnaround time. Now we've worked with providers over the last 2 years to help them to submit the necessary documentation immediately. Our pharmacy turnaround time is less than 4 hours, 100% of the time, and the average time for authorization is 51 minutes. And there was testimony yesterday regarding being on hold for hours. I want to assure you that we have service level agreements with our pharmacy benefit manager that requires all calls in the hold queue be answered within 60 seconds, 93% of the time. And there has to be a rate of 5% or less for abandonment of those calls. PA is important in the pharmacy world because it allows us to maintain a preferred drug list, which then allows us to negotiate for supplemental rebates, and that accounts for about $24 million in 2023. And then finally, the DVHA team is exploring an option for electronic submission. That's what I alluded to yesterday through the provider portal, which all providers use anyway. So the CMS rule that was released yesterday kind of ensures that the Medicaid agencies are doing that. So I think that covers stuff that came up yesterday. And then hopefully we'll assure you that we're on this totally. We want to support the providers and reduce the burden.
Okay, we have a couple questions. Thank you, Sandy. Leslie, Topper, and Alyssa.
Yeah, thank you. Could we get a copy of your testimony?
Yes. Can we get a copy of your testimony, Sandy?
Sure. It's kind of in note form, but I can make it. Yeah.
That'd be great.
Yeah.
Thank you.
Yeah, all the data and everything, that'd be helpful. Second question, if I may, earlier you were talking about the federal rule, and I just want to make sure I understood this right, allowing insurers access to EMRs in order to sort of decrease involvement of providers. Is that what I heard?
I can also share the policy review of it with my notes. I can include that instead of trying to answer.
Yeah, that'd be great.
Yeah, what I'm wondering is included in there, we have so many different EMR platforms in the state. Does DVHA have access to every platform? how does that, I mean, that's technical, I get it, but it's a bit mysterious to me how that might work.
I think probably you would want our team that works on the MDWAS program. I think there are a specific data team with that they are managing that whole project, and they will speak to it better than I can.
Thank you.
That was my question, all the platforms.
Yeah.
And I think Vital plays in there somewhere. Yeah,
If they're supposed to.
yeah, yeah. So we can get more information on that. Alyssa?
And just, you said that you guys have eliminated, I'm sorry, I shouldn't say you guys.
Y'all have, y'all.
That's not my Diva
My
has.
personal goals is to not use that, so I appreciate it.
Diva has eliminated prior authorization requirements on a multitude of things. What do you still have left? Just sort of broad categories.
I can follow up with that. I can't give you a specific list. A dental cone imaging is one of the things that comes to mind. So we brought that to the Clinical Utilization Review Board, and they indicated that they didn't think it was a good idea for us to not have that. The imminent harm code list, that list that I said was reviewed annually, anything that has the potential to cause harm to members, they all require prior authorization. There's also TMS services, transcranial magnetic services. I think
Batteries.
it is. Those require prior authorization. So there's a few. I would have to go to the actual list.
Are there minutes? Are there minutes from this review board?
Yes,
Are they on the website?
yes.
If you could send a link to that, that would be terrific, because I'm having a difficult time finding it. But thank you very much.
Art?
Got it.
Well, and this may be a question for you, Lori. I just want to make sure I understand what this piece of it is for. Is this for Medicaid?
Yes, this is for
Okay,
Medicaid.
I
Yep,
lost
sorry.
that in the translation.
Yes, this
So
is
this
for
is
Medicaid.
Medicaid.
Prior auths, yes.
Okay.
And
so-
our bill does not impact Medicaid.
Right,
as
we're
written.
just finding out about it.
Yes.
But is Diva's prior auth less or more onerous at this point than the private? Do we know that, or does it matter?
I think someone provided testimony yesterday that it wasn't as onerous.
Yes.
It wasn't less onerous?
No, it wasn't as onerous.
It wasn't as onerous
Correct.
as
And
the,
in the conversations that have happened over the summer on prior authorizations, the little bit I was involved in, but when we have everyone back in, we can ask him this question. Medicaid was not normally discussed as an issue.
right. Will our bill correct some of that and make it closer? What I'm getting at is I don't think Medicaid should be given less of a thing than the, the commercial people.
Right, so I guess there's one couple ways to look at it. So as I was sitting here listening, Medicaid does a very good job.
Yes, they do.
On providing the quality care
Yes,
at
they
an
do.
affordable price. And I'm wondering if we can follow some of their lead and have commercial insurance.
I
What they
tend to agree with
Yeah.
that, and that's what I was trying to get at. I mean, it should be the same. I mean, they should be
We would
very,
love
very
that.
close.
We would love, I will say, I would love
But I
that.
don't know if Blue Cross Blue
Right.
Shield would love it or
Exactly.
MVP.
So what we need to do
Okay, I get
is have this conversation, bring people back, talk about the differences. So
Got it.
we're far from done.
my pea-sized brain gets it.
Okay, great. Great.
I think I wanted to that point, I really wanted to amplify something that Sandy said, which is, you said that you have tracked utilization since getting rid of vast swaths of prior authorizations, and you have seen no discernible change. Change in costs.
Right, so
Utilization.
right, so the point is, they eliminated prior auths. They did not see an increase in utilization, which is what some people say will happen. Therefore, they did not see an increase in cost. And most likely Diva did not, but most likely providers saw a decrease in cost of having to work with Diva on prior
Oh, I would think
authorizations.
it would decrease costs. I hope that's part of what this is.
That's why I want to see that data in our.
And I appreciated your statement of trusting providers and having that professional, like, faith in them, these very skilled human beings that are caring for our community. So I appreciate that a lot. Thank you.
Just one quick other question, Sandy. I don't know if, you know, how long you've done this, but have we, if someone has a procedure that goes wrong, that is not required, what PA was not required, are we liable somehow, if there's a lawsuit?
Oh, Medicaid?
Yeah, or the commercial people, okay, they don't have prior auth for a certain thing, and then it goes wrong for whatever reason, the person sues, can the state be, or the,
I don't know the answer to that question.
I just wondered if it ever came up.
And just shaking her head.
You
I
know,
mean,
how come you didn't
I don't know.
authorize this?
yeah, I'm not, I think it all depends on the situation. And if something goes wrong in a medical procedure, it's probably more than just a prior auth issue.
Yeah,
Right,
we could be part of it.
right.
Yeah.
If for any reasons,
Yeah.
right? Yeah.
Well, allegedly, you're not supposed to do the procedure unless you've got authorization to do it.
Right. Right. Well, but that's between the doctor and the patient.
Yeah.
Yeah. Leslie.
Well, I'm just thinking, like, what's the difference between Medicaid and the commercials? And it's about profit. Diva has a different business model, so I don't know that we can compare them. I'm just thinking out loud and wondering how that works.
We can ask,
They have
and we
different-
bring people back.
Yeah, they have different motivation, let's say.
Well, I would say that they are not, Blue Cross Blue Shield is a nonprofit entity. And their motivation, as they stated, is to care for their members who have Blue
No,
Cross.
I totally
Blue Shield.
believe that, but it's not about, I'm not saying that, but they do have a different kind of margin or need for than a state agency. I'm just want to be sure I understand.
Well, they have to cover costs just like Diva does. So I want to be careful of what we say an insurance agency's motivations are. So
That's fair.
let's be careful of that. And it's something we could ask when they're sitting in the seat, which they are not right now.
I think I just wanted to expand on what I think Art was getting at was sort of, can you hold the insurance liable for malpractice? And I'm just thinking, if you cannot hold them liable for malpractice for requiring a PA, then I can't imagine that you could hold them liable for not requiring one. And I'm thinking like the instance that the provider shared with us yesterday about a patient of his who was required to get prior authorization, but didn't understand that, just thought that her copay for this drug that was keeping her stable. And she ended up in the ICU.
Right.
So if she wouldn't have been able to essentially sue the insurance for requiring prior authorization, I can't imagine that you could sue the insurance or Ziva for not requiring it.
Yeah, I don't, that's the way.
I don't know. I mean, that's way out of our,
Yeah.
but I'm just thinking about it from the other perspective.
Right.
I mean, there is a contrast between the numbers. I mean, it's really impressive what you said about the call waiting and.
Yes.
Yeah, really impressive. So just trying to
Yeah.
contrast, we were on the phone for hours, we
Right.
heard multiple people saying that. So what's going on? What's
Right.
the contrast?
Right.
That's what I'm
Right.
thinking about.
And I want to be clear with everything we heard yesterday. Providers are not just talking about Blue Cross and Blue Shield and MVP, which is where we have our qualified health plans, but it could be, all sorts of insurers that are out there that people have.
Right.
In Vermont, so. Okay, so, thank you, Sandy. If you can put your notes together in a readable format for us, that would be great. If you can link us to the report, Daisy asked for, and if you could also provide a link, and I don't know if this is even available, like a link that a provider would use to determine whether or not they need a prior auth for you. So that we can just see how that works. Because we heard testimony yesterday that sometimes it's very difficult to even know if a prior auth is needed, and a lot of time is spent trying to find that information. Great.
The report you said that you're looking for, you mean the link to the curb minutes? That's what I jotted down. Was that?
Yes, yes, that's correct.
Okay,
Great.
thank you.
Great, thank
Have a nice
you. Have a
weekend.
great weekend.
Bye-bye.
So let's come back at 11 and we'll do some committee discussion about a couple housekeeping things. It is not really related to any of the bills, but we can talk about questions if people have questions about the bills we've been talking about.